Don't know me, my name's Andrew, I'm one of the GP trainees placed here at the moment, and I've done a literature or a journal presentation based on SSRIs being used as an alternative to HRT for the management of menopausal hot flushes. So the reason I picked this topic, I was trying to think of something that might be GP relevant and obviously had a slanting interest for people here at the Women's as well. And thinking back to my placements and foundation training at general practice, I thought, well, quite common to see ladies coming in asking questions about HRT, being uncertain about whether they could take it. Just thought, are there any alternatives? And then I'd read a small piece in a journal about SSRIs that have been used mainly for the management of hot flushes, which I found was often women's main concern around that time. And so I wanted to do anything to see if there was any evidence to support their use. So the aims and objectives, I suppose, to see if there's anything that could be offered to women other than HRT, and if there's any evidence to support these alternative treatments. For me personally, I suppose it gave me the opportunity to search current guidelines, do more literature review, develop my evidence-based practice, and to critically appraise a systematic review. And then again, really, more I think about the alternatives to HRT. For me, rather selfishly, in the future as a GP, it could be relevant. Obviously, pretty an ongoing thing, controversy about use of HRT and how safe it is, and that's pretty much an ongoing debate. Lots of uncertainty about complementary medicines that have been used in the past as alternatives. Like I say, SSRIs was something that I read about, so I decided to look into. So I suppose the question I was thinking of, population's obviously well defined, women around the age of menopause. Intervention was the use of SSRIs, and to compare against the other options, so either HRT or not having any treatment, and the outcomes, seeing how effective they were to reduce the severity of hot flushes. So that's pretty much my question. What evidence is there to support the use of SSRIs as alternatives to HRT in reducing severity of hot flushes in menopausal women? So we start off with Anne's help. Thank you very much. Performing a nice search. There were no current guidelines, but they are in the process of developing a guideline. And you can see there, menopause, diagnosis and management of the menopause, which is due to be published in July of 2015. As for the RCOGP, there's no, that's just stuck in my head, RCOG, not GP. There are no green top guidelines, however they have produced a patient information leaflet. There was no Cochrane systematic review that we saw, so we then searched PubMed using the key terms menopause and SSRIs, and limited our search to systematic reviews and random controlled trials. So we found 11 references after that restriction, and only one of those was a systematic review that addressed the question. That's the reference there. So back in 2006 now it was published, but as I say, it was the only systematic review that really addressed that question, so we focused on that. And it's non-hormonal therapies for menopausal hot flashes, as they're called in America, rather than hot flushes, and systematic review and meta-analysis. So there's the paper. So in terms of the methodology for this paper, they started off by looking at the databases that you can see at the top there, looking for relevant trials that gave any data on treatment of menopausal hot flushes using non-hormonal therapies. The databases there, Mantis and Ahmed at the bottom, they didn't find any relevant trials. So they said that they included trials that have been published in English language, randomised, double-blinded, placebo-controlled trials. Their endpoints, if you like, they were measuring the frequency and severity of hot flushes, and they did include patients who were on who had previously had breast cancer and were using medications such as tamoxifen as well. So they included those and grouped them separately from their other cohorts. They interestingly excluded head-to-head trials comparing non-hormonal medications with HRT. Their eligible trials were reviewed for quality, and they used the consort checklist to look at look at those, which I think Anne's going to talk about either now or a bit later on.
Well, the consort checklist is typically used to review the reporting of a trial rather than the methodological quality. So we sort of question that they use that, but they do say that they used something alongside consort, but they don't give any details.
The
so
STORB,
we're not.
isn't it? They use mainly for quality checks, STORB checklist, isn't it?
Pardon?
The STORB checklist, they usually use it for quality check.
Well, there's various checklists that you can use to assess the methodological quality of systematic reviews, including, as we well know here, CASP, there's ANSTAR, there's Cochrane, there's a BMJ one, so there's lots. So it's not usual to use the consort, so I sort of question why they did that.
And they then performed a meta-analysis to determine how effective these therapies were. So this is a summary, if you like, of their search and selection. So it started off with 4,249 potentially relevant abstracts, and we're able to filter this down to 429 relevant articles, which were reviewed. Quite a lot of these were excluded, so left them with 43 randomised control trials which were considered for meta-analysis, and only 24 of those were deemed relevant, and those included 6 trials of either serotonin selective reuptake inhibitors or serotonin noradrenaline reuptake inhibitors. And I suppose the summary of this section, so looking at those medications, the bottom line is probably the key point. So all trials combined, so that's everything there, and the plot you can see just here. So that's the key thing. So the mean difference in the number of hot flashes per day, which basically approximates to 1 fewer hot flushes a day. So I suppose the key question, which they don't really address, is, and we have the discussion as well, if you're having 2 hot flushes a day and you reduce it by 1, then fantastic. But if you're having 5 or 10, then it's not really all that helpful.
It's neither here nor there,
No.
really, is it? 1 less flush a day, whatever you might call it. It's neither here nor there.
The other interesting point was, you can see, so at the bottom they've got trials where estrogen receptor modulator drugs, so things like tamoxifen, are used, where those information is combined. You can see it sways the plot and brings it much more in favour of SSRIs or SNRIs, whereas without those results included, it's pretty equivocal. It doesn't show that there's much evidence for them. And in terms of the quality of the papers they've looked at, and this is by their own assessments, they've only got fair and good sort of quality trials, and quite a small number that they've looked into as well. So we then thought about whether the results of the review were valid. Obviously the population and the intervention were fine, they were clearly identified. Like I said before, we were dubious about, in terms of the outcomes, the number of hot flushes. Maybe it would have been better to grade things on a wider basis. How were the lady's symptoms overall, rather than being that concrete, and maybe having a measure, because like we've just said, 1 fewer hot flush doesn't really tell us anything. So they reviewed the random control trials well, and evaluated the intervention. So in terms of wanting to make a valid case for these, I suppose they did it in a systematic, thorough manner. It was well thought through. So biases and things like that we could think about, and ways to improve. They didn't include non-English language studies. We thought they could maybe have considered NEM-based search as well, being more specific to pharmacology matters.
M-base is drugs and pharmacology, a database for drugs and pharmacology, so it would be useful if they searched that one as well.
And then, as much as Anne said earlier on, it's not really clear how the quality of the randomised control trials was rated from their methods.
We don't know exactly what criteria they used, to be fair, so.
And there's not really a standard measure of the symptom severity included either. This is just a summary as well in terms of the results. So bearing in mind we were just interested in SSRIs really, but they looked at some other medications as well. And overall, there's not really any evidence for any of these other medications. So they use things like clonidine, methyl-dopa, gabapentin, and then soy extracts as well, which all showed some improvement. And then the interesting thing that we thought at the end, they put severity or composite score, the percentage difference, which wasn't really mentioned otherwise in the paper, but then they've used it to sort of grade as a percentage. So in the SSRI group, a 10 to 36% improvement, but that's in 4 of their 6 trials. So in terms of thinking, are the results helpful? They didn't include any p-values, which they could have done to indicate whether they were statistically significant. They compared with placebo rather than HRT, which may have given an idea of the actual effect of the medication, but in terms of clinical application, it might have been helpful to have some evidence to say that this is how they actually compare to using HRT. Didn't take into account really the side effects of the medications. A couple of the reports did say that patients had stopped using higher doses of antidepressants, for example, because of the side effects. And I suppose it would have been interesting for them to take into account the additional benefits of the medication as well. So other than having an effect on hot flushes, it may have been that it helped with ladies more in terms of their mood, obviously being antidepressants, so maybe to look at the medication as a whole, whereas we were just looking at the effect on hot flushes, maybe to consider the benefits overall would have been a better option. So I suppose, in summary, we're not really any clearer about how effective these medications are, but I suppose the take-home point I thought from it was in patients who have had a history of breast cancer and use medications such as tamoxifen, so HRT would be pretty much contraindicated for them. At least there is another option to have in mind and to think about if ladies are really struggling with hot flush symptoms. Thank you very much.